We'd like to invite back Dr. D'Olimpio to lead our session on palliative care. So I'll let you do the introductions. Thank you.
Terrific. Thank you.
Good
morning. So we talked about amongst us this wonderful panel that is going to introduce themselves in a couple of minutes. What really are some solutions to the gaps that we talked about yesterday. So without further ado, what I really wanted to do was, this is our title slide for the day, and let's go to the sixth slide, the last slide that I spoke about. There we go. Future directions, this is our theme. Earlier is better. How is it better regarding our whole group here? And we wanted to talk about pretty much all of these areas, especially section 4. So without further ado, I want to have Sarah come up. Sarah, please introduce yourselves again and maybe go over this area that we wanted to talk about with the unpeeling of the onion.
I am Sarah DeBoard. I am a patient. I was diagnosed over 7 years ago when I was 34 with metastatic colon cancer. I am inoperable, so I have been in treatment ever since, which means a lot of chemo and a lot of targeted therapy and a lot of side effects and a lot of changes to myself and my family. I have 2 little kids. One was a baby when I was diagnosed, so I've had to raise my kids in the world of oncology, a world that not only isn't designed for young adults, it's definitely not designed for young adults that have kids and careers and need to work in treatment around staying alive and raising their family. And palliative care is something I knew about. I never really applied it to my own life because I'm what I would call an empowered patient. I kind of, there's a hole. I very much lead my own healthcare. My oncologist and I work closely together. He pretty much does what I say. But I was able to build my own support system. I live in the Twin Cities. We have amazing cancer support groups, nonprofits that provide the needs, the psychosocial support that my family needs, that I need. So I didn't feel like I had any unmet needs. I knew where to go if I needed anything. So I created what I called my onion and my layers of care. It didn't mean that I didn't know what palliative care was, because I did lobby at the state level and at the national level for palliative care. There is a bill that we're trying to get passed that would help fund more training for palliative care and hospice education. If anybody wants to know about that, I can talk about that later. So I knew what it was, but I didn't think it needed to be applied to my life because I'd already created this, what I would call my own onion. And it wasn't until I started writing about it for Cure magazine that people started to come out of the woodwork and educate me more about it and kind of say, hey, maybe you should actually see a palliative care doctor just to see what it's about, make sure you're covering all your bases. And I kind of reluctantly said sure, since it was covered by my insurance. And I am treated at a comprehensive cancer center, so I knew we had a great palliative care program. I did not tell the palliative care doctor that's what I was doing, researching an article, when I met with her, but it didn't take long in our meeting to quickly realize that, you know what, there are gaps in my care. Here I was thinking I was so empowered and so strong as a patient, but she quickly weeded out little holes where it's not that I was lacking anything, but by filling in those holes, it would improve my quality of life and take it to the next level. And so I designed what I call the layers of palliative care to kind of illustrate what it looks like for me. And at the time, I had my oncologist at the center. They were my go-to for everything. And for me, and I think a lot of patients, we assume our oncologist knows everything and they know how to deal with all the side effects of treatment, but more often than not, the oncologist only knows how to treat the disease. They don't know how to treat the patient or some of the side effects. And so I have, in my onion, the oncologist kind of at the center. And the next layer for me is a radiologist and a surgeon and a pharmacist. Now, I don't have a relationship with the surgeon because I had a colon resection and 3 days later, everything was working perfectly again and has ever since, but I've not had any repercussions that I needed to visit a surgeon again, but I still put them in that outside layer. I have a personal relationship with my pharmacist at Masonic Cancer Center. The pharmacist is actually in the infusion room, and he goes around and talks to every patient at their appointment to make sure they're managing their disease, they're managing their side effects. He and I work collaboratively. If I hear from another patient about something that worked for their nausea or something that worked for their cetuximab rash, he'll take notes and do a little research because he also wants to help other patients. And obviously a radiologist because if you're dealing with pain and obviously with scans, they're going to be kind of in that second layer. The next layer for me is the specialists that help you manage the side effects. Again, most oncologists that I've had, and I've had probably 5 at this point, don't really know how to deal with all the repercussions of the disease. I developed lymphedema about 3 years after I was diagnosed and had my surgery, and it took my oncologist through 2 weeks of me going in every day going, what's wrong with my leg? Before he finally kind of said, oh, I think I need to send you to the physical therapist. They have this way to wrap your leg and make that all go away. But I was kind of shocked to see that, this is a very common side effect of cancer surgery, and he didn't really know anything about it. I've been dealing with a chronic cough from lung inflammation, probably a result of all the chemo I've had and lung meds. And, I had that cough for 18 months. And it wasn't until I went to a pulmonologist at my own behest that I was finally able to kind of resolve the cough issue. I've had side effects that have affected my nails, my skin. We talked a lot about fertility yesterday. A lot of my friends with ostomies still routinely see their gastroenterologist. And so that outside, or the next layer, kind of encompasses the other specialists that we can incorporate into our care to help, again, improve quality of life. And the outside layer for me is the support systems. Like I said, in the Twin Cities, we have amazing nonprofits. We have a Gilda's Club. We have an amazing organization called the Angel Foundation, which provides programming for my kids, provides a free camp they get to go to every summer, and monthly meetings for preteens and kids and teenagers, and just provides that additional therapeutic support that my kids might need or might not even talk about needing. One of the things that kind of surprised me when I first met with the palliative care doctor, and she was kind of going over my care, is she asked about my spiritual needs. And I thought, you're a doctor, like, what are you asking me about my spiritual needs for? But she said, on my palliative care team, we have a nurse, there's me, and we have a chaplain. And I was kind of taken back. Like, what does my spiritual needs and a medical doctor have to do with my spiritual needs? But as I stepped back and really understood palliative care, I realized it's not about taking care of the physical, it's taking care of the whole patient. And I think a lot of times, as doctors, you're trying to treat the disease and the physical person, and palliative care just takes it one step further and looks at the whole person. And for me, that includes my kids. If my kids are taken care of, if their needs are met, if they are coping with cancer and the transition it's made in our family, then I feel better. It helps reduce the stress and the burden of my disease, knowing my kids have a support system. So it therefore improves my quality of life. And so the outer layer includes what I kind of put into the support system, which would be a social worker. And we've got 2 here today. They're going to talk about how they help, in that outer layer, counselors, mental health, which is a huge issue for anybody facing cancer, but it's one the young onset community is really starting to be public about and talk about. Sorry, I cough. Because, we are dealing with things like anxiety and PTSD and depression, and those are things we normally don't want to talk about, but, we need help with them. When you're looking at terminal disease and you're looking at being young and facing end of life, that's a lot to take in for somebody who has little kids or who's barely had a chance to start living their adult life. I mentioned our community support, which fortunately I have because I live in a big city, but I know in a lot of rural communities, those programs are few and far between. The spiritual support, and then support groups. I wouldn't be the empowered patient I am without my online support community. The one I'm happen to absolutely love is Town, and it's a patient-led community support where I'm able to find out about other ways to treat my disease, clinical trials, where I can go for second opinions, and just find that emotional psychosocial support online as well. And so this is what I call the layers of palliative care. It kind of illustrates what it is for somebody that doesn't quite grasp what it is. And again, I'm fortunate to be treated at a comprehensive cancer center where we have this system in place. I know, again, in a lot of smaller clinics and hospitals, palliative care is lacking. You're not going to have the resources. So one of the things I would like to address, and we've talked about, is how can we get this type of care and this kind of service to some of those smaller communities, to some of those smaller hospitals? Because as Dr. Olympio mentioned yesterday, we don't have enough doctors and nurses trained in this to meet the needs of the entire community across the country. So that's, I think, one of the burdens that we need to kind of help lift for other patients. But as we are keeping patients alive, and as we're getting towards that cure, finding all these amazing drugs that are keeping people alive with chronic disease, I think we need to focus more on how can we make sure they maximize their quality of life. Oh, sorry, I'm trying not to cough. how can we maximize their quality of life? And I think incorporating palliative care or support care, as you call it, I think that's a great way to put it, because the word palliative can be kind of confusing, especially when it gets lumped in with hospice, which is something that really frustrates me, is changing the patient perception, changing the provider perception, and helping people understand palliative care isn't about end-of-life care. It's for anybody facing a serious disease, and it's all about improving their quality of life despite the expected outcome.
Thank you very much, Sarah. That was great. Really. Really phenomenal, right? Just a couple of overarching themes, words that everybody's going to talk about. One is the word holistic. As a physician, we sort of pushed back on that word a little bit over the years. It really does mean what it's supposed to mean when it's talking about palliative care and supportive care. The other overarching theme is quality of life. And I want this to be the section that everybody's going to be hopefully participating in. We're all going to speak for a few minutes, but we all agree that I think that it's important to have an interaction between us and the audience. So this is going to be probably a good 20, 30 minutes we'll be able to have that type of interplay, okay? So without further ado, our next speaker would be Susan.
Good morning, I'm Suzanne, and I was the caregiver for my son Chase Johnson, who was diagnosed at age 24 and passed away at age 28, was diagnosed with stage 4 colon cancer. As I said yesterday, age is not a factor, his health, also no family history. Next slide. Or am I supposed to click? Okay. So I just brought a couple photos, so you kind of get to know our story quickly, and then I'll just tell you a little bit about my concerns. That's our family. That was our last family vacation that we took with everybody, was in 2010, because he got diagnosed in 2011. Next slide. So I put 1 week. That's 1 week before Chase was diagnosed. He was running Twin Cities Marathon, did a decent time, and then the other slide is 1 week before he died. We took him on his bucket list trip to Vegas for a couple days, came home, and went straight to hospice in my home. Next slide, please. Palliative care. Sarah talked about some great experiences with palliative care. We did not find out about palliative care till middle December, and Chase died in January. So we did not have, even though I live in the same city as Sarah, we did not have the knowledge or the services that Sarah had. And we were navigating it and didn't know what there was available. But quickly I found out what was not in the services that we really needed as a family and as a parent and also as a patient. Next slide. So really mental health is really what I want to mention. So you'd have changes in the family system when you're going through something like that that's traumatic. Your boundaries are going to change in the family. All my kids live there. They didn't live at home anymore because they're in their 20s and 30s, young adults. Our roles changed on what we were doing in the family, and also our style of communication among each other. Who was going to do what, who was taking Chase somewhere, who was going to be his appointment, and who was going to be his support team. A lot of anxiety came with all of us among that, but because we weren't familiar with mental health, we didn't talk about it. Other changes were, a lot of depression, the trauma, Sarah said PTSD, trauma during the whole experience for all of us that we still live with today. And Chase lived through that every day. He was going through those experiences and just trying to be a 20-something-year-old enjoying life with his friends and having a great job at Piper Jaffray. Next slide, please. So you have grief and loss when you're dealing with something like that. Not after the person's died, obviously you have grief and loss, but as you're going through something like that, there's a lot of grief. And so how do you deal with that as a mental health issue? And so as I listed there, Chase had a lot of things that he lost in quality of life, and the patients yesterday talked about that. And I saw Chase going through that, but I was going through my own, so it was really hard for me to talk to him about that. Plus, he's a 20-something guy, and who wants to talk to their mom about all these personal things? Not Chase. So he would joke around about stuff, but he would certainly not come to me. And then our family times all of a sudden became times talking about mental stuff and what we were dealing with and health things. And it was sometimes hard to really enjoy those family times that we had had in the past. So we really really had a loss of all those family times and our vacations. Chase died before my son, my other son, had any children, so he missed out being a uncle or a parent himself, so a lot of loss on himself. Okay, so next slide, please. And this is our family now. It's, as you see, I have my grandchildren and everything. And due to my experience, I went back to school right after Chase died, and I've become a marriage and family therapist with a focus on working with families dealing with cancer, because I really saw that that's a need for everybody that's in the family system to be able to navigate this during that disease. And if also you lose somebody, how do you deal with it afterwards? And as I said yesterday, every day I carry that pain of Chase not being here and that hole in my heart. People think, oh, I don't want to bring up his name because it might get me upset. Well, you know what? There's not a moment I don't think about Chase, and I don't remember all those great times and all the things he misses and his friends that we still see, and I see them get married, I see them have kids, and he never got to experience that. So mental health is so important with these families that are dealing with this, along with the patients at the same time. So thank you.
Again, another really tremendous perspective. Some of the terms we use in palliative care with regards to what Susan went through, what we call existential suffering. And existential suffering really involves a lot of different things regarding the loss of significance, the broken story of one's life. All of these things break into what palliativists know and supportivists who do palliative care know is going through with these patients and their families. And the grief that goes through is sometimes very complicated and always present, always present. It's the complications that we try to deal with. And I think, Susan went through this in really great detail and with great insight. So we have a few more speakers, and we've talked all about them. I think, Andy, do you want to go next? Sure. That would be great. And followed by whoever wants to follow him. We're going to be doing this very free-flowing, and we want to have some time for questions.
Hi, my name's Andy Esch. I'm a physician. I have two roles, I think, in my career. One is I work for the Center to Advance Palliative Care, an organization that focuses a lot on the things that Sarah talked about in her presentation, which are educating colleagues on what palliative care is and how it can benefit patients and families and caregivers. Educating directly to patients and caregivers about some of the misconceptions of palliative care. Again, Sarah alluded to, hospice and palliative care kind of always being lumped together, but I would assure you they're the same but very different. And if there's one message I hope everyone takes away from this morning's talk is that palliative care is based on need, not prognosis. So especially in young folks that get cancer of any type, colorectal or otherwise, it's important to know that. Palliative care is based on need, not on prognosis. And if you remember that going away from today, I'll feel like I did CAPC proud. I also have clinical responsibilities. I do serve supportive care of Orleans County as the medical director. It is a small rural practice that sits between Buffalo, New York and Rochester. And we set our record in the history of our organization. We have 34 supportive care patients today. So that's a big deal for us. It doesn't sound like a lot, but it does answer some of the issues that Sarah brought up, is that there is an access issue. And that is one of the things I'm trying to solve in my clinical career and with my work in CAPC. So hopefully I can answer some questions when we get to the Q&A. Thank you.
Who wants to go next?
I'm Karen Bassiano. I was here yesterday too. I'm a clinical psychologist. I work in the Department of Psychosocial Oncology and Palliative Care at Dana-Farber in Boston. And I've been working, my clinical practice is specifically in working with young adults and working with them sort of across the illness trajectory, but often with young adults who have more symptom burden and advanced disease. And I think one of the things to think about in terms of palliative care for younger people is that there actually are some different issues given where a person is in their sort of adult, in the part of their adult life cycle. And I think we heard about some of them earlier, but I just want to kind of emphasize that they're related to, relationships that are younger in terms of like either, trying to find a mate or a relationship that's younger and maybe doesn't have the same kind of longevity and strength to deal with a crisis such as this. There are issues in terms of having young children or thinking about having children. And all those things are really important in terms of issues like advanced care planning that are unique for young patients. And I think one of the things that I do a lot of in my practice is consult with palliative care physicians and nurse practitioners who are doing clinical work on helping them to support young patients in the best ways possible. And I do a lot of work helping young patients who have illnesses that will take their lives think about legacy work, which is different when you're a younger person, and what they want to do and how they want to be remembered. So I think one of the things that I wanted to contribute to today and to have open the discussion to are what are the unique issues for young people in palliative care.
Thank you, Karen. My name is Krista Nelson, and I work, obviously, Karen and I were talking today and had very similar goals. I'm an oncology social worker. I'm from Portland, Oregon. I was up here yesterday as well, so sorry if I repeat anything, but I specialize in working with kids who have a parent with cancer and have developed some programming around that as well. I think similarly to what Karen and Sarah have both shared is, especially with people who are younger, they're in a different phase of their life cycle, and they're having a real disruption in their identity. And that can be their social identity, their physical identity, and their community. I think so individually, who am I as a person, and feel, really robbed from some opportunities that they may have had, sort of go through that existential crisis of why me. And I think the most important reason when you look at the title, why palliative care, why early, why now, it's because really the whole discussion and all of this is really around creating a space for patients and their families to communicate. And I think that's also something that is different with someone who's younger than older when they have cancer. They may need permission to ask their family for support. They may need permission. They don't have anyone in their peer group who has cancer. So, creating opportunities for people to connect around that and what really does make it different. And even though people are living a long time, it doesn't, I think people are often referred to oncology, like psychosocial support, because we're willing to sit with people and have discussions that are hard. And to be able to sit with people and say, we know you didn't want to be here, but I'm wondering what you're thinking about, what you want out of the time that you have left. We're willing to just sit and hold that space. We are as hopeful as our patients are that their life is not going to be over anytime soon. And we want to be sure that the time that's left is quality, that they have the people around them that they need to support, and to know that that's going to change over time, what they need. What you need today might be really different next week. And so I think just the benefit of palliative care is that you're always offering support and checking in with people throughout their treatment. And Sarah, I don't know, you may have not wanted support right at the beginning, and then we're like, oh my gosh, bring it on now, and I'm okay right now. And I think the real key with working with young people is allowing them to control the cadence that you offer support as well. This is not a one and done palliative care consult. We are on this journey with you, and we're willing to be with you on good days to celebrate. We're going to celebrate those wins like we heard yesterday, but we're also going to celebrate and sit with you in the hard times. So.
That was such a great point about communication. I thought that was really, especially during the phases. One of the things that we really had a great experience with from Dana-Farber, because we worked with Vicki Jackson and with and Dr. Temmel about all of these things, had to do with their training, their interactive training that they went through with their videos. And they went through different phases of what you were talking about along the course of the trajectory of the disease. and the different types of communication scripting, the concept of pendulum swinging, the concept of I'm wondering about what to do, or the power of the open-ended question. These are the things that many oncologists don't have time for. They ask a lot of closed-ended questions. Do you have this? Yes. Do you have this? No. Do you want this? Yes. Do you want this? No. It's sort of like that, as opposed to, can you tell me what you understand about this? And these are the kinds of things that those tapes were really, really helpful with, and it helped us in the early palliative care study that we participated in bringing those types of, even Angelo Volandis would say, vital talk training in terms of how you put that into a different perspective. So there are tools for communication that can be dispersed, that can be really practice changing. I think Andy brought out the fact that CAPC has these wonderful educational tools now. So we can bridge the gaps from the standpoint of specialized palliative care, which might not be available in Butte, Montana, but is available in Boston, Massachusetts, right? So generalized palliative care, in which you actually have those concepts, those abilities, those helpful resources that can bring that to the Midwest, to the areas that really don't have this, so that we can get an earlier palliative care referral just based on the fact that those concepts are available for you. So this is pretty much what we wanted to talk about. And since everybody sort of gave their spiel really wonderfully, are there any questions in the audience? I mean, I can barely see anybody with these lights. So I'm looking at it this way.
Just piggyback on one of the things you said is that I think that we also do very similar things with patients, is that a lot of my work with patients is helping them communicate, helping them ask open-ended questions, helping them identify what they need, helping them talk about both their hopes and their fears with people in their support system. So I think there's a focus on palliative care communication for professionals, but I also think as providers, as psychosocial providers, we also help patients to ask those questions and have those discussions that, are not in the normal life cycle of a young person to be having those discussions. So often with some coaching and some help, that those things can really help reduce anxiety and distress for them.
Great.
I have a great illustration of that. And when I met with my palliative care doctor, she asked the same question that every doctor had asked me before and checked the box. Do you have a healthcare directive? And I'd always say no, and then they'd move on to the next question. And she asked me the same question early on, and I said no, and she goes, well, do you want to put one together? And I was like, yeah, I know I need to. It's the kind of thing I would tell other patients, we all need to do this. And so she printed off and handed me the I think it was 5 or 8 pieces of paper and said, take this home and look at it, and do you want to come back and have me help you through this? And I was like, well, sure, because I didn't know anything about end of life. I've watched plenty of my friends pass away, and I had my own fears about it being traumatic or painful or miserable, and so I wanted her help and her guidance in filling it out. What I didn't know is that I would sit there sobbing for an entire hour as we talked about what I wanted for end of life care, and the role my children would have in it, which will always make me cry. But what it did force is I named my dad as my agent. And it forced me to talk to my dad and send him a copy of it so that he had it. And I think it forced my dad to face the fact that I had metastatic cancer. I think my dad looks at me and he watches me on Facebook and he sees me traveling all over and thriving with this disease. But I think sometimes my dad even needed kind of that wake-up call to say, my daughter still has an incurable disease and she may die one day. And the fact that he had to kind of walk through what I wanted with me was probably a great point of communication that we hadn't had, and it was gently forced through my palliative care doctor in the best possible way. So I think when you talk about opening communication lines with family, I think you gently force us to have necessary conversations.
And totally opposite.
Yeah.
Usually you're having that with your dad because he's ill.
Yeah.
Right? Yeah.
Yes.
I think as a patient, one of the hardest things that we deal with, which you were talking about, is the access to care. For instance, I live in Austin, Texas. I travel to MD Anderson, which is 3 hours away, to get my treatment options. I see a psychologist there. Now, I have to make the choice between leaving my family for at least a day, to travel out there for an appointment or foregoing it because for some reason in Austin, a major city, there is not access specifically to palliative care and integrative care for cancer patients. I actually have a colostomy, and I was told when I asked about a woundostomy nurse, we don't have any information for you. If you find somebody, let us know. And that was my oncologist office, and I was just shocked. And I think people are forgetting that, yes, you can use the online resources and, you know, interact in that way, but there's a big difference for especially people like me with that personal touch. I want to be able to see that person. I want to be able to interact with them in a room, know that when they see me cry or break down or I'm sharing a joyous moment, that they're in it with me versus through a screen. How do we even work with the breakdown that's happening in major areas too? Because rural areas and underserved areas, it's a nightmare. But the fact that even in large metropolitan areas, this seems to be a problem everywhere. So how do we bridge that gap? How do we make it so, first of all, everyone understands that they need palliative care, but that there are facilities specifically for that, not just at the big cancer centers, but I'd like to see facilities that that's all they're for. We're a center, we don't have infusions here, we don't have, it's just for cancer integrative care.
Well, that's certainly an integrative portion of what is missing. And I completely agree with what you have to say. Andy, can you comment on accessibility issues that was just mentioned, I think, very powerfully?
Yeah, so one of the places I would urge patients and caregivers to turn to is getpalliativecare.org. I know that's not personal, but it is an online site that is kind of the one-stop shop for where to find resources that do exist in your area. And I actually think what you're talking about is a perfect role for a palliative care team to help coordinate care for a patient who is looking for somebody to put together everything that needs to be done. And so, you know, the directory on getpalliativecare.org will tell you where the sites are closest to you. And I think if you do find palliative care, I think you will find it in your area, and you link up with one of those teams, you will get it. And they should be able to do that for you. I will say, though, that there still is a big gap, for lack of a better word, of availability of palliative care everywhere. But it's one of the goals of organizations like mine to train enough people in specialty palliative care to make sure we have enough providers, and also to educate our colleagues about core palliative care skills through education and online training and those things, to make it so that even if there's maybe not designated palliative care in your area, there are providers that possess those core skills and know who to call for help to give you the care that you need. So, I mean, you're identifying one of the challenges for our field. I do think it's getting better. In the 5 years I've been with the Center to Advance Palliative Care, it's gotten a whole lot better, and I think it will continue to do so. But use the getpalliativecare.org site to see where the resources are for you locally.
Susan wants to say something, but before she does, I just want to mention one other thing. In New York State, we have a law, because sometimes going through a statute can be important. It's called the Palliative Care Information Act. And it was, I believe, passed about 7 years ago, and about 13 other states have something similar. And the way it reads in general is, and this is New York, so you have to sort of keep this with a grain of salt, is that if a physician, meaning an oncologist or someone taking care of a cancer patient, recognizes the fact that that patient has a life-limiting illness and does not and is not comfortable with talking about that particular aspect of their care or the supportive aspect of their care, that physician or advanced practice professional needs to find for that patient a palliative care referral and give that patient the referral. If they do not do so, there is this is New York State, remember, this is a $5,000 fine and 6 months in jail. Now, I only say that to the fellows to scare them. But the point is that it exists, and the point is that I think other states, I'm not sure about what it's like in Texas.
I would have to say that would be a
Serious no-go in Texas, fair enough. So these are the kinds of things that we kind of think about, and in some places they do pass these types of laws. But laws are made to be circumvented in certain situations, the spirit of the law, of the actual law. But I think Andy's point is well taken. Sometimes there has to be a starting point. And I know for sure in Austin there's some palliative care resources. I just don't know where they are either. But Susan, you wanted to say something.
Yeah, I just want to advocate really from a family and a patient perspective. I mean, we walked in that oncology office, never having cancer in our family, and rocked our world. And we needed that oncology doctors and those infusion room people and nurses to tell us that this is available. And nobody ever talked to us about it. 3 years we went there for all these treatments, went to Mayo. I mean, I live in Minnesota. Went to Mayo, went to Minnesota Oncology. I'd ask them, we need mental health. Chase needs somebody to talk to. I need somebody to talk to. Well, I don't have anybody for you. And we needed to start in the doctor's office. I didn't know about palliative care. How would I know about that? I had never dealt with cancer before. How would Chase know about that? So great to have resources, but if you're hitting this blind and you're blindsided and you're on this emotional roller coaster with this disease, you don't know this information. I was a retail district manager at that point. None of us were in the medical field in my family, so we did not know. So I really advocate for the medical field to tell us.
And it's such a great point because, many times, in the medical field, everyone is so busy that they don't have the time to learn about it, or they don't go through the CME credits, or that are not mandatory. I think if you would, this is my own personal opinion, that if you make them mandatory, I think that would make a difference. We have, again, in many states, an infectious disease course. It's just 3 arduous hours, and you have to go through that, pass a test in order to get licensed. And again, in New York State, they had to pass a law stating that if you were going to prescribe opioids, you have to take a course on how to prescribe opioids. And if you didn't take this course, you couldn't do it. Now, there are 55,000 physicians in New York State, and only 5,000 physicians took that course. So what does that mean? That I am overwhelmed, and many of the other pain physicians are overwhelmed with the fact that the other physicians did not want to go through that process. So in order for you to sort of get through that, you might have to make it mandatory for the hospital that they're affiliated with to mandate that they have to take that in order to get hospital privileges. Right. So there are various ways around it in terms of delineation of privilege, but the points that you bring out are so heartbreaking that I think that it needs to be brought out in a different venue, in a different space.
I just want to say I'm so sorry that it's hard, I think, for us who do palliative care and work with younger patients to hear that they're having to be the one to advocate for themselves. But I would encourage you, anyone who has an oncologist, their office and their cancer center is likely accredited through the American College of Surgeons, and they require that, part of that is that they screen for psychosocial distress, and if they don't have someone on site, that they have someone that they refer to. So I think before there was palliative care, there was sort of oncology social work. So my guess is that there is an oncology social worker in your community. I know several, actually, so you could contact me offline if you want, to be able to provide supportive services to you in your town.
Wonderful.
I did contact that person. She said, I'm not sure who to put you in touch with. She gave me a few names, and I called them all. And one person I heard that from 8 years to tell me, I'm sorry, I can't counseling right now. And I'm like, no, but and they don't specialize with cancer patients. So I don't know if
it's not just nice, it should be required. And you're not stupid and you're not selfish. You're just the opposite. And this is the part that we're really trying to fix. Even in palliative care, being able to be trained in oncology with the specialized needs of patients like yourself is a huge gap to be filled. And that's why we're here, and we're going to try to help that. And I think this conference is really an initial starting point, a seed, if you will, that you are contributing to watering. And I think that's an important distinction that we have to make. We have another question?
Great discussion yesterday and today, and so that's sort of the where. I'd like to bring it back to the when. When does this start? You know, because now we really see this more of a supportive role, not just an end-of-life role, through the process, even if that's not. Help the doctors understand when we begin to have that discussion, you know, stage 2, stage 3, older, younger. Help us understand.
I'll speak to that and kind of answer, you know, part of the gap in what Susan and Chase experienced. I asked my palliative care doctor how the oncologist knew to introduce this care, offer this care, and she said with the University of Minnesota in the EMR, at the first appointment for a patient with any serious illness, it's actually triggered. And so in that system, it's built into the EMR to recommend or ask if they want to see it. But obviously, for me, I had, like a lot of patients, I had to go seek it out because I was kind of already in the system before, you know, that was established. But I know, and I don't think what the stage matters. I think it's more, they're dealing with an illness that's going to affect their quality of life. You know, and I have friends that had stage 1 disease that ended up with ostomies or, you know, pelvic radiation damage or, you know, things that are going to impact their quality of life forever, even though they never did an ounce of chemo. And then, you know, there's people like myself or Diana who are living on chemo. And so, you know, we're dealing with a lot of side effects. But I don't think stage matters. I just think the fact that they're facing a serious disease and they want to maximize quality of life is all that's important.
Yeah, I just want to say real quick, this goes back to that palliative care based on need, not prognosis. So, you know, it can benefit patients from day of diagnosis, but the important thing I think to keep in mind is that palliative care is very much like a medication. It's dosed. You may not need a lot of palliative care early on when you're doing well, but having introduction to that team and familiarity with them will allow you to maybe have more contact with them and more interaction with them when things change. So I think earlier better, and I think a good palliative care team that's working with your oncology folks and all the other docs involved and other teams involved will dose it so that you get what you need when you need it the most.
I just want to comment that we have about 10 minutes left. 11 or 12. So I know we have another question here, but I just want you to think how you want to use the rest of the time, if we want to take more questions or if you want to sum up.
Okay, thank you very much for this space and letting me ask my question. I was just wondering if you could please discuss your experiences with the nurse as part of your interdisciplinary team. And as a nurse researcher, we're interested in using the biopsychosocial model as part of one of our conceptual models in research. And just how do you see perhaps nurse researchers getting to the table and helping bring your voice to the research that you hear going on? Do you think that we could help play a role bringing your voices to a more integrated model of research?
I can try. So one of the things palliative care, one of the huge challenges is, how do you measure a good outcome with palliative care? All the metrics now are quantitative, like did we get advanced directives filled out? Did we do a MOLST? Have we grown in the number of consults we've seen? But what about qualitative? So as a nurse researcher, if there's a way that you can work with palliative care teams to help them develop a measure of qualitative outcomes, I think that would be huge. And whether that's, you know, some satisfaction scores or some indirect measure, I think that would be a real bonus to the field moving forward.
We had a medical student at Hofstra over the past summer who was working with one of our nurse researchers, and it had to do with her idea of taste alterations impacting quality of life from what chemotherapy can do. And certainly chemotherapy can affect taste, which is a huge thing no matter whether you're going through chemotherapy or whether you're done with it and your taste has been altered. And it went from that to, well, how can we fix that? And we found some actual resources and some interesting areas where we could maybe go forward with it. So many times the research that Andy mentioned has to do with an idea, a spark, and being able to bring not just the quantitative aspects, which I find boring and I find difficult to put together in an EMR because it will come up right away, but many times you say, well, the doctor doesn't really want to do that, but then, I do both, but, where do I put this in terms of the sequence of events that might take place? The syringe of palliative care or supportive care, you give a cc, right, at the very beginning, and then 3 cc's in month 3, and 10 cc's in year 2, and, that kind of a conceptual framework. But the qualitative aspect, you cannot put in an EMR, I don't think. But you might be able to develop tools that would be able to be put ex parte or ex post facto into an EMR, which we have been able to afterload after we've come up with those ideas. And in fact, all of our supportive and palliative care aspects came in an afterload fashion in our EMR, which is all scripts. And originally we didn't have anything, and now we have enough so that at least we're able to get started with some things. A great question, by the way.
Can I speak to the physician who asked about when to do it? What was coming up for me is really partnering with your particular palliative care team, because I'm also aware that, like we've heard, we don't have capacity, we don't have enough people trained to see everybody. So I think really partnering with your team to say, what is your capacity? And if you do have other patients you want to refer, how can other team members, other social workers build in that sort of onion of support around without the official palliative care team? Because I think we can provide palliative services without an exact sort of team, and that might be a warm handoff to the palliative care team down the road. So just wanted to say.
And what you really need is a champion, I think, or several champions in order to get that happening, in terms of putting together. And the guidelines for quality palliative care really brings us out in really sharp focus, is that each individual vignette in a different kind of healthcare system or hospital or clinic really needs to be sort of resourced in different ways. It's idiosyncratic, as I mentioned yesterday, that you might not have the funding to do it, but you have to have a champion to be able to make that happen, or a series of champions that you can turn on to be able to get that to happen, I think. Any other questions? We'll be wrapping up. Maybe 1 or 2 more questions.
Hi, I don't necessarily have a question, but I wanted to bring something to the table. I'm a long-term, I'm a 15-year survivor. So I feel example, like once you ring that bell, you're gone. You're no longer seen, cared for, things of that nature, except for doing your yearly colonoscopies is what I get. But what I wanted to bring up was the fact that for a very long time, I was told by my doctors, my gynecologist, to get a hysterectomy. And I had a really hard time facing that. I knew that I couldn't have children, but it was just the fact that, like, okay, this is real now. Like, this organ is out of your body. But once I actually decided to do that, I had the strength to finally to get the hysterectomy. I got the MRI, and my uterus was attached, to other organs, and it was too much of a dangerous surgery. So after this doctor told me years and years and years to get this hysterectomy, and I prepared myself mentally to finally get it, he told me he would not do it. So that broke my heart. I left the office in tears once again, like I did every time I went there. So then luckily I did find a new doctor, and whenever he looked at my MRI results and he knew that I had Lynch syndrome, he actually asked me about getting retested for Lynch. And that was really confusing to me, because I'm like, do genes change? Does Lynch go away? And I think it was, for me, I took it as he was making an excuse to not do it. And I get it was a difficult surgery, but that was my life that I made that decision, because it's the second leading cause for Lynch. But I just don't want people to forget about the long-term survivors. I had something else to say. But That's it. That's all I wanted to say. And also, whenever I came back from the Colon Club, which I was just recently in, I learned a lot about myself. Both being a 15-year survivor, I forgot a lot of things. So when I came back, I made the initiative to make the doctor's appointments myself because I didn't realize how many other cancers I could actually have. And no one ever followed up with me besides my GI doctor to get a colonoscopy. So I never had any MRIs. I wasn't getting my kidneys checked, other organs. So I just wanted to make sure that everybody in this room, please, the nurses and the physicians and everything like that, please don't forget about us long-term care survivors.
It's a whole section now on at ASCO where long-term survivorship, which we know very little about, some of the data is starting to mature now, in terms of what areas are so important, and you mentioned so many of them right now in terms of accessibility and doctor shopping, which is just so unnecessary, at least it should be. But survivorship is very important, and some of the long-term side effects of chemotherapy do involve that. But at any rate, I think that it's really important that we keep that in mind in the whole sphere of what we're trying to do. We're going to have to wrap up. Are there any other questions? Oh, okay. I'm sorry. We have two more, and then we should be able to wrap things up.
Okay, hi. Okay. My name is Carlene Taylor, and my 22-year-old son was diagnosed with colorectal cancer in 2016. And then he passed away at 23, 7 months later.
Jesus.
But while we were in the hospital, and I know this is about the palliative care and the gaps and everything, and there were huge gaps for us as far as compassion and faith being part of the caring situation. So my question, I guess, is with the palliative care, the only time it was brought into us was as a pain, to alleviate his pain. So there wasn't anything else, any time else brought into the equation. And I don't know where the palliative is supposed to start and end when it comes to, faith and compassion and paying attention to the human spirit. And everything for us was he was first diagnosed at stage 2, and I won't go into all the misdiagnoses and the missteps that happened that led to where we got to. But once it got to the point that he was stage 4, it was pretty much like, well, this is it. There's really not much more we can do for you. And, even though he wanted to fight, we wanted to fight, it was pretty much like, these are the hardcore facts, and we're just going to move on. So what I feel the huge gap was paying attention to the patient and to the family and to the faith and the compassion and the human spirit and bringing all that stuff into the equation. And we didn't have that. So I don't know where that's all supposed to feed into the clinical portion and the textbook portions and all that kind of stuff.
Well, I'll answer this, and I really want any other participation. Having faced this as a palliativist in the hospital for many, many years, and having been exposed to this type of terrible grief, I think pain management is just one block in the multiple blocks that need to be put into this. And grief and bereavement counseling is part of the palliative care consult. And pain management is part of it, but all the other aspects of the psychodynamics behind what you mentioned is also part of it. So if that's an area that needs to be improved upon, I would certainly, advocate for that with you. And I can only say how, heartbreaking this is that you weren't offered that, because complicated grief is a natural outcome of what you went through. Complicated grief can last for months and years later, and needs counseling in order to help mollify it. So again, I couldn't be more heartbroken about what happened, and I wish it didn't happen that way. And it shouldn't have happened that way, and this is part of the gap that we're really trying to fix. But thank you for sharing, and we all feel the same, I'm sure, about your grief.
I would just add that when I spoke earlier at my very first palliative care appointment, she asked about my spiritual needs because part of her palliative care team, it was her, a nurse, a social worker, and a chaplain. And so he was a core member of her team. I also sit on a palliative care advisory board for our American Cancer Society Cancer Action Network with the state lobby. And on that team, in fact, I was just at a meeting with a congresswoman with him, is a minister. And so he works as a chaplain in the hospital, so he does a lot of hospice care in general, but he also works on our palliative care advisory board as our chaplain. And so he does represent the spiritual aspects that are brought into palliative care.
Thanks very much. Cindy?
I just want to thank everyone here on the stage. We spent a lot of time putting this together. I truly enjoyed our conference calls, and I want to let the audience know that this is just the beginning. Dr. D'Olimpio mentioned this is just a seed, and that's the way this whole program has been designed, that this is just the starting point. Later today, this morning, we're going to move down to the hall, and we're going to break out into groups by gap and basically come up with an action plan how to address these issues. So I encourage you to, again, stay, come with us downstairs and be part of the brainstorming that's going to take place and participate moving forward. A round of applause for our panelists, please.